What are the main causes of restrictive pulmonary disease, and what would a spirometry trace look like if you had a patient that had restrictive pulmonary disease? Watch this video to find out. So welcome to this short lecture on restrictive pulmonary disease. In this lecture, you will learn the different ways to categorize restrictive pulmonary disease based on the cause or the etiology. And then finally, we'll look at a spirometry tracing, or the way you do PFTs, and see how a restrictive-like disease would appear on this PFT tracing. So let's start over here at this diagram. So it's a very schematic, basic diagram of the lung and the body wall. And so what we're going to first try to figure out is how do we normally breathe through mechanics, because the crux of restrictive pulmonary disease is that we have a problem getting air into the lungs, opposed to obstructive lung disease, which is a problem getting air out. So that's the first thing you need to remember. Restrictive pulmonary disease is a problem getting air in. So a big part of it is a problem with breathing mechanics. If you haven't watched our videos on breathing mechanics, Mike's done a number of them. Go and have a quick look at those and then come back. So here in this diagram, what we've got is a lung in the middle, and then we've got the body wall on the outside. So what we essentially have to do to be able to breathe in, so to get air into the lungs, is we need to expand the lung out. So we need to, these things on the outside are what we call our ribs. That needs to go out. Down here is our diaphragm. That needs to go down. So that needs to go down. That needs to go out. And the vertebral column at the back needs to flatten off. So that kind of needs to go out. Now together, all those things, what will happen is it will expand the lung in every direction. By doing that, the volume of the lung gets bigger, the pressure drops. Therefore, air wants to come in and fill it up. Now, the essential problem with restrictive lung disease is air's not coming in to what it should be. So the problem is either a problem with the outer wall, it's trying to pull it out. These are extrinsic problems. Or the lung itself, which normally should be like a nice elastic balloon, nice and compliant, meaning as the wall goes, the elastic balloon of the lung goes with it. And when you're ready to breathe out, it just recoils back like a balloon would. This doesn't happen. So the lung is stiff, rigid, not compliant. And these are what we call intrinsic causes. These are problems with the lung itself. So the first thing I want you to know is what would cause some extrinsic problems or what could cause some intrinsic problems. Either way, you're going to get a restrictive pulmonary disease if these things eventuate. So let's start with extrinsic. These are problems with the outer mechanics of telling the lung to expand. One of the first things, and this is in no order, but I'll just move anatomically up to down, is the respiratory center. So the respiratory center. So the problem here is up here in your brainstem, you have a center that regulates your breathing neurologically. It regulates it and it sends neurological signals down to regulate the dynamics of your breathing. If you have a problem with your brainstem, either through trauma or taking certain medications, this could impact the way that your breathing is carried out, and that would possibly cause a change in the dynamics of your breathing, thus being an extrinsic cause. So the respiratory center is one. Another one is a problem with the chest wall. So the chest wall could be the bones, like the vertebra, or the ribs, or the sternum. So if you've got fractures, for instance, or a problem with the bones, it's not going to go out as it's been told to. So some common examples of chest wall deficits would be kyphosis, so you're bent over, scoliosis, you're twisted to the side or together, kyphoscoliosis, a big problem with that expand the chest. So that's some examples of chest wall issues. Another problem could be a problem with the diaphragm. So the diaphragm, as we know, is the main respiratory muscle. So if that is not being told to contract, let's say through a neurological problem, such as a paralysis, that's not going to go down, the lung's not going to expand, air is not going to come in. So diaphragm issues is also an important one. Another one would be neuromuscular deficits. So this is where there's an issue between the muscles, such as the intercostals between the ribs, and the nerves. So this could be a problem like ALS, so this is like a motor neuron disorder, or Guillain-Barré syndrome, or polio, or MS. This is a problem with coordinating nerve input with muscle. They're not working together, therefore chest wall's not going out. Another extrinsic could be the pleura. Here in green, you can see the pleural cavity. That's important because as the chest wall goes out, it takes one level of pleura with it, and then it takes the other one with it. So that together allows the dynamics to happen. Now, if in here you had some complication like ongoing inflammation or scarring or thickening, or like a chronic pleurisy, that would also cause problems with the dynamics of breathing. That's another extrinsic cause. Lastly, the final cause within the extrinsics is something wrong with the abdomen. So abdominal issues. So down here, if you had too much weight, so obesity, that would have a problem with the lung being able to go down. If you had a really big liver, so hepatomegaly, so a large liver, that's also going to have a problem with it going down. Or a lot of fluid in here, such as ascites, which you might see with portal hypertension. So that fills up with fluid, the lung can't go down. So this is other causes. So all of these are extrinsic causes of restrictive pulmonary disease, all to do with the body walls, the chest wall not going out. Now we come across to the intrinsic causes. This is fundamentally a problem with the lung itself. So now this is where the lung isn't compliant. The outside's fine, the lung isn't. It's a thick, rigid, stiff lung. Some of the ways to categorize it. Now, one important point here is when we look at the obstructive diseases, there's only about 5 to learn. With the restrictive pulmonary diseases, there's like over 200. So it's going to be very hard to understand them all. So to be able to categorize them makes it much easier for you to understand. So we've already done one grouping through extrinsic. Over here in intrinsic, of those 200, probably 180 of them are over here. Okay, so another method of trying to categorize intrinsic or specific parenchymal issues with the lungs is through these examples or subcategories. So one would be, I'll just put that, occupational / environmental. So this is basically either through your job or through your environment, you're exposed to certain things that could be either organic, you're breathing in either organic toxins or chemicals, or inorganic chemicals or toxins or particles that would react in your lungs to cause scarring and fibrosis. Some examples in terms of occupation, well, we have something called farmer's lungs where they breathe in spores from the hay. We have something called bird fanciers lungs where if you work with a lot of chickens, you breathe in things coming out of their feces which also go into their lungs and that causes reaction. Then we go to maybe more environmental. We have like coal miner's lung or silicosis where you maybe have a person who's cutting a lot of concrete. All those particulates that coming off from the concrete goes into the lung and causes issues. And then asbestos that we know about, which was used for insulation in building, that also causes problem there. So that's one category of it. Another one is idiopathic, which means we just don't know what's happening. Or we don't know what's essentially caused it. Pathic. Intrinsic, or interstitial, should I say? Interstitial meaning between the alveoli spaces, so in the kind of extracellular space between the alveoli sacs, interstitial pneumonia. So basically in this category, a good example of this would be idiopathic pulmonary fibrosis. So for some reason, your lungs are going into a chronic form of inflammation and laying down lots of scar tissue. And then we have another category, unfortunately, just called other. And in here we have things like sarcoidosis and eosinophilic pneumonia. A lot of long names. Now, the best way I can kind of simplify this is all of these causes, which are intrinsically a problem with the lung, what's essentially happening is scar tissue is being laid down in the lungs, like we see in a chronic inflamed reaction. So what has to happen is there has to be some kind of cell injury in the lung. Then we have the start of an inflammatory process. We have more vascular permeability, more plasma proteins going out into the tissue space, more activation of pro-inflammatory mediators. The white blood cells come in and try to clean things up. Now, this process with the process of trying to heal it is this long, drawn-out process and issue which causes scarring to be laid down. So a lot of fibroblasts, a lot of collagen is put down and makes the lung very stiff, very rigid and non-compliant. So really all these conditions, even though they are quite different in terms of their cause, the fundamental outcome is that the lung becomes scarred and stiff and non-compliant. Now when we look at these two categories of causes, in spirometry, we can see what we would expect to see with the functions, the pulmonary functions of your patients. So let's turn over. So what we have here now is two traces that you would typically see if you were to do pulmonary function tests. Over here, we've just got basically volumes and capacities of your lungs, of your patient's lungs. And here we have the dynamic measure of spirometry, that being volume over flow rate. Okay, so a volume loop here. But let's start over here and let's start with a normal trace in normal lungs. So what we can see here on the y-axis is the volume of air in a person's lungs. Now when you are at rest and you're breathing normally, what you will be doing is just breathing passively in and out, in and out. Now that is what we refer to this here as tidal volume, or TV, which is approximately only about 500 mils of air just going in and out, meaning all that's happening is the diaphragm's contracting and going down and then relaxing, going back out, which requires the recoil of the lungs being nice and elastic. So air's just moving in and out. Now, if we wanted to fill our lungs up to its full capacity, so if we wanted to take a deep breath in to the full maximum, what we're doing is we're filling up the air in our lungs to the top point. Okay, now that amount from where you would normally have breathed, from the top of your tidal volume all the way up to there, is what we call a reserve volume. Now this is breathing in, so we call it inspiratory reserve volume. Okay, so this is the maximum amount of air that you can fill your lungs with. So if you were to go from that 0 point of no air all the way up to the top point, what that would give you, all that amount, is the total capacity of your lungs, total lung capacity. Now for an adult male, this is around 6 litres. Okay, now think about it, this is like you blowing a balloon up to the maximum point before it busts, okay? It has a lot of potential energy in it because it's elastic and it wants to recoil quickly back down. And this is what's going to happen here. When you let that go from that breathe in and then you try to get it all out, all that air coming down to rush out to the bottom point, that means that's the last part of air that you can get out of your lungs. Now, the point of the bottom part of your tidal volume on expiration down to this point where you can't get any more air out of your lungs, that is also a reserve volume. Okay, but unlike inspiratory, this is expiratory reserve volume. Okay, now what you did from here to get all that air out is something that you have control over. So you have an ability to be able to dictate being able to do that. And what we call that point, from filling your lungs up to its maximum capacity to emptying it to its empty capacity, is what we call the vital capacity. You have control over that. Now, right at this bottom point where you can't get any more air out, you would think you've completely emptied your lung. And what happens at this point, this is like a battle between your body wall trying to pull your lungs out and the elasticity of the lungs trying to pull your lungs in. Now, they come to a point of equilibrium about there, which means that the lungs are trying to pull it further in, but the body wall's stopping it. So there is still a bit of air left over in your lungs. It's not completely empty. And so we call that residual volume. That means there's still a bit of air filling your alveoli sacs, millions of them, with a little bit of air, but collectively put that all together and you're left with a residual volume, which let's say is around 1 litre of air. That's very important. So when you add up all these values, that's going to give you the total lung capacity. And the air that you can really have control over is your vital capacity. They're the important values that you need to remember. That is for a normal person. Now remember, before we move on, we always compare it to your perfect self, meaning what your lungs should be. You don't compare it to, say, Dr. Mike or to Donald Trump or to some athlete. You compare it to what you should be. And so the variables that you should know for your patients to be able to do that comparison is their age, their sex, their race, and their height. You plug all those in to the computer when you do your spirometry and it gives you a predicted value. So when you do these tests, it has to be comparing to what it predicted to what your lungs should be, to the perfect you. And basically anything lower than less than 80% of your predicted value would be considered a problem or abnormal, okay? So we saw the normal trace. Now what happens in a restrictive lung disease, we know we either have a body wall issue and it won't pull the lungs out, or the lungs are really very tight, very rigid, very non-compliant. So when you try to breathe with stiff lungs, you're not going to be able to even do tidal volume very well. So that trace is going to get smaller. When you try to breathe in, your either body wall's not going because of the extrinsic causes, or your lungs are stiff. So it's not going to go up to here, it's only going to go halfway, let's say. And when you try to get it out, that recoil is very poor because it's stiff. So we're not going to get that out too much. And so in restrictive lung diseases, all volumes go down. Okay, so tidal volumes down. Inspiratory reserves volumes down. Expiratory reserve volumes down. That means vital capacities are down. Now, just to finish on that, because your lungs are so stiff and non-compliant, and they're actually a bit too pulley on the against the body wall, that even means the residual volume drops. So that actually means that litre of air that you normally would start on is less. So we actually start from a residual volume much lower. So in restrictive lung disease, even the residual volume's down. So every volume is low, it kind of shrinks because either intrinsically your lungs are stiff, rigid, non-compliant, or there's something wrong with your body wall. So that's in the static tests, okay? Now we go across to the dynamic test, which is doing this in a time forced manner. So when we look at this particular diagram, what we're seeing here is the lung volumes. Again, we did that here, but we do it over time or flow rate. So this is the speed of air moving out of your lungs, okay? So on the x-axis, we just have the litres of air, which we could see here. But here is the speed of the movement of air. Now, this is a normal person. Okay, we saw that the residual volume for a normal person was about 1 litre, so we actually start at this point. So when you breathe in, let's say you try to do this quickly. So you breathe in maximally, this is what we see as a trace, which is the same as this. Okay, so it goes all the way out to here to 6 litres, which we saw to here. And then we try to exhale as quick as we can. down we go. So we have a very quick speed of air that's leaving the lungs very quickly because that has the most potential energy, like that balloon, trying to force the air out very quickly. So we have a lot of air leaving very fast, and then it slowly slows down, slows down, slows down. So this is just a flow rate, all to the point where we started again, which is down here. Okay, so what we have in that, we have this value from here to here, which we saw from here to here. That's residual volume. Okay. We saw the maximum point of inspiration, which is the same up here, and then you exhale it out all the way down to here, which is the same as going from here to here. So remember we said the point of maximum inspiration to emptying your lung from here all the way down to here is vital capacity. Okay. Now you put all that together, and that gives you total lung capacity. Okay? Now, for a normal person, remember we do it to predictive values. Now, let's have a look at what it would look for a restrictive lung disease. First difference is we start with a lower residual volume, because remember, all volumes go down. So we actually, let's say, start with 1/2 a litre. Now, your ability to go to that height with inspiratory reserve volume is less. We saw that. So instead of 6, we come to 4. So we only go out to here. Your ability to get it back, all that out, is diminished, and particularly the speed. So it's going to be a lot lower. You're still going to come back to that point. So what's going to go down is the vital capacity has gone down, which we saw over there. The residual volume's gone down and the total volume's gone down. Now, in this trace, this is under speed. It's forced. So we don't have the vital capacity like we did here. Over here, we've got a forced vital capacity. So it's the vital capacity over time. It's dynamic. It's trying to see how quickly you can do it. In a restrictive lung disease, just like we saw here, the VC will go down, so the vital capacity will drop. Now, the other important measure that we want to see here is how quick you can get the air out over a very short period of time. So what we would kind of do is we'd try to figure out what is that amount of air over that time, which is about 1 second. And what we call that is forced expiratory volume in 1 second, 1, which gives you a good indication of how the flow rate is. Okay? In restrictive lung disease, this number is also down. Okay, so FEV1 and FVC is down. Now, if you did the measure of the ratio of FEV1 over FVC in a restrictive lung disease, because they both go down proportionally, what we see is actually that the number is normal to increased. Okay? Compare that to obstructive lung disease like COPD. What you would see with COPD is this number would definitely go down dramatically because they can't get the air out quickly. That's the problem with obstructives. But this number remains kind of normal, which means their ratio drops dramatically, let's say below 70%. And that's when you have a ratio of these two, under 70, that's classic obstructive traces. But in restrictive, because both of them go down, the actual value is normal or actually increased, which is a good indication of a restrictive trace. So in terms of the dynamic tests, the most important thing you should be looking for is a normal or an increased value with that ratio, whereas over here in the volumes and capacities, particularly the most important is the total lung capacity. If the total lung capacity is going down, that is restrictive, whereas if it goes up, it's obstructive. So that's the take-home message you should remember. Over in the volumes and capacities, well, all the volumes capacities go down in restrictives, but you're particularly looking at total lung capacity. And then over in the dynamic testing, you're looking for a normal or an increased FEV1 FVC ratio in restrictives. So hopefully with that, you've now walked away with understanding the different ways to categorize restrictive pulmonary disease based on cause And then when you look at the testing, the pulmonary function testing, you know what trace is indicative of a restrictive condition, both in the volumes and capacities and the dynamic testings of spirometry.